Okay, so I already talked about the theory bit. So this is how it looks like. And if you see the cerebral processes going extended like that, the diagnosis is a PHP patient. So I'll just come to the video. You can pick it up on the CT scan, MRI, whatever you want. Could be anterior, posterior, differential diagnosis, management surgically has to be done because these are the ones which should not be operated because they're off center. The ones which need surgery are these ones. And what you need to do in surgery is, it's very simple. Okay, I'll start the video. Okay. Now this is a case in which if you notice, you can see there's a fluid droplets inside, and this is off the center, you can see the vessels down there. And the anterior capsule X has already been done, so cortex is gone. I've just gone to the PHPV. Now if you cut this one, there's a big font which is going down at the back with vessel, it will bleed. So we started using plasma blade in this one. So we're using plasma to make the cut. You can see the posterior vessel which is going, that a thicker vessel. And this was positive on the M mode. We did a scan in which we could pick up the Doppler, so blood was flowing actively into this. So we done a posterior axis with this one. And now the trick is how to take it out. You can use plasma blade again to cause the central part to shrink. You just put the plasma there, give little pulses, it will start shrinking a little bit. And then what you need to do is you have to make this vascular vessel into avascular by frosting it. You just go under it, put the tip and frost it at two places, about 6 millimeter behind the plaque. And then you can actually go with a scissor and cut it. So this was the first time in literature anybody used plasma for this purpose, and after that we done a number of cases. So now I'll come from the side again. Now this is anterior axis. You can see this is the posterior axis here, which has got a plaque. So little plaque on this off the center is always helpful because your lens placement can be done. And this eye was almost a normal size, so we had gone with the implantation in this eye. Now you see I'm going behind and again giving the plasma and trying to make the red one go frosty white. Now this is going frosty. It's actually getting coagulated now. So once, in fact, in the first case, we did more because we didn't want the bleed to happen. Because in the literature, they said if you cut it like that, the vitreous will be full of blood the next morning if you leave this patient like that. Now we got enough, around more than 5 to 6 millimeters at the back. Then your scissor comes in from the side, and we just done a little overkilling here, which could have been avoided, but since it was one of the first cases, then we went with the, sir. Okay, now why didn't we do a vitrectomy or pull it out? Because we didn't want any traction on the vitreous. So we just cut it and let it go. The posterior retracted on its own, and the anterior one stayed there, and that's about it. And then we went with a vitrectomy probe, and then we cut the anterior one and ate it. And this patient, actually on follow-up, now it's about 3 years old, has got a vision of about 6/24 partial in this eye, and the parents are happy. So once you do a cutting here, now all the vitreous is gone, the posterior stump has gone back, and there's an anterior posterior, both our rims are intact with me. So this is an ideal patient in which you can put a single piece lens, and that's what we did in this patient. And if one of the rexus margin had gone off, I would have put a 3-piece in the sulcus because the eye size was normal in this patient. And that's what it looks like now. And we always do a PI in these patients because these are the ones which were prone to a secondary glaucoma later on. But this patient, after plasma, doing with the plasma, gave a very good result. Thank you. Now we can have all the questions, please.